You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Okay, we're at 11:08, so we'll get started here. Our second presentation today is by Dr. Nikita Raje. She is our immunologist at Children's Mercy, and she will be talking on evaluation of recurrent infections, or more, I guess, correct as inborn errors of immunity. Thank you.
Dr. Miller. All right. So as Dr. Miller mentioned, I'm one of the immunologists here at Children's Mercy in Kansas City, and the topic is evaluation of recurrent infections, but this is purely an immunology talk. So we'll be focusing on inborn errors of immunity, not so much like infectious disease information. And let me know, I hope you hear me well and you can see the slides. All right, they are advancing. So I do not have any disclosures. Here are our learning objectives: to recognize various causes of recurrent infections, to classify primary immunodeficiencies, now known as inborn errors of immunity, and to outline the tests for various types of immunodeficiencies. So here's our outline. So these are the questions that we are going to try to answer today. Why is it important to work up patients with recurrent infections? And what kind of infections should we be worried about? And once we know that these infections need to have a workup, what kind of diseases should we be thinking of? If that's inborn errors of immunity, why are we worried about inborn errors of immunity? And how common are these? And then large part of our talk today is going to focus on how do we evaluate for inborn errors of immunity and what kind of inborn errors of immunity are we going to think of. So let's get started. So why is it important to work up patients with recurrent infections? Well, we know, it would help us reduce morbidity, reduce mortality for life-threatening infections, but prevention is better than cure. If we know the cause of those infections, we can actually make sure that we put preventive measures so that those infections do not occur and help save some resources. And then the underlying cause can have other implications other than the infections. So then what kind of infections should we be worried about? There are lots of infections. People can come in with just colds and sinus infections. So when should we be worried about? So if the infections are recurrent, and that's a little subjective, so we'll put it in perspective over the course of this hour. Severe or life-threatening infections. If the infections are in unusual site or organ, so infections, 5 sinus infections in a year may be still within the normal range, but even a single infection in the liver or infection in brain, those are sterile organs. So if you see an infection there, you have to be concerned about it. If the infections are resistant to optimal therapy, so that optimal therapy can vary based on infection. So if it's a sinus infection, you give oral antibiotics. If a sinus infection needs IV antibiotics, that's out of the norm. You would think that that's not a usual occurrence. So again, that would be unusual. Opportunistic infection, at any point, there has to be some kind of predisposing factor, whether it's an inborn error of immunity or some other condition. So now that we know it's a problem, what kind of diseases should we be thinking of? So primary immunodeficiency, that's the talk. So that's pretty obvious. We'll be talking about those and thinking about those diseases. But as you see, I've numbered it number 3. So there are 2 other things that we should be thinking of more frequently: secondary immunodeficiency and other causes. And the reason why I numbered them this way is because those causes are way more frequent. Immunodeficiencies are rare disorders, but as a group, they are common. So we have to keep them in mind, but common things are still more common. We have to think of other causes of infections and secondary causes that can affect the immune system. So what are the other causes? These can depend on the pathogen that's causing the infection. There can be host factors that can be predisposing those patients to infections, or some environmental factors. So different kinds of infections, bacterial, viral, fungal, parasitic, opportunistic, can occur in different scenarios. Um, Smoke, there are some environmental factors like smoke exposure or a kid going to daycare, just weather related. So winters, you'll see patients come in with, yeah, we have sinus infections about twice a year when the season changes, more when it's fall and winter. So that's pretty common. And then host factors. So the ends of the age, those patients are really at higher risk of having infections. Some genetic factors. There can be anatomical issues, just structural issues that can cause patients to be at higher risk for some infections. And then comorbidities, think of diabetes, can put some patients at increased risk of some infections. So there can be several different comorbidities that can predispose to certain types of infections. All right. Well, so I think we went through some of these factors here, exposure in daycare or siblings who are going to school. This is a very common scenario in our clinics. Smoking, we don't think of too much, but passive smoke exposure can also be a predisposition to certain types of infections in early childhood. Just having reflux and aspiration can lead to lung infections. Just having seasonal allergies or nasal polyps, those can lead to recurrent sinus infections, or having bronchiectasis can present with frequent lung infections. Sometimes we see patients who have asthma in our clinic who come in with frequent infections. Those infections are likely just viral colds, but because they have asthma, the asthma flares up and it looks like a lung infection because there's just no way of, they have fever, they have cold and cough symptoms, and they have breathing issues. So pretty common to confuse that with recurrent pneumonia. Atopic derm can present with recurrent skin infections, and then structural issues like primary ciliary dyskinesia, cystic fibrosis. You'll see these patients with frequent infections as well. Well, there are some causes that lead to defects in the immune system, but the defect lies outside the immune system. So these are conditions that secondarily cause an immune defect. So there are some infections that can suppress the immune system, like HIV, EBV, CMV, or nutritional defects like zinc deficiency, protein calorie malnutrition, although less common in this part of the world. There can be lots of medications and medical therapies that can lead to immune suppression. So we know of corticosteroids, chemotherapeutic agents, biological agents, immunosuppressants. Irradiation can also suppress the immune system. But even simple medications like antiepileptics. So keep in mind that make sure you look at the medication list when patient comes in for evaluation of low immunoglobulins or infections. Look at their medication list. Conditions like asplenia can also cause increased risk of some infections. We talked about age. There are some protein losing conditions like nephropathy or enteropathy that can lead to loss of immunoglobulins, and that can lead to increased infections. Although most of these patients do pretty well because their immunoglobulins that they hold on to are still pretty functional. And then there are some disorders like cancer, autoimmune conditions can also predispose them to having more infections. All right. And then, of course, we are going to be thinking of inborn errors of immunity, right? So that's the name that was suggested a few years back, just because it encompasses lots of inborn errors or immune defects that are not a defect in the immune system, but there is sometimes gain in function of those immune molecules that can also lead to disturbance of the immune system, lead to infections and other manifestations of immunodeficiencies. All right, so taking you back to medical school here. Let's look at the basics. The cells of the immune system, all of those come from the stem cell in the bone marrow. They, as we had some choice in our career, have choice to be either a lymphoid cell or myeloid cell, and then different types of lymphoid cells, B, T, or NK cells, versus myeloid cells can become all these kinds of different kinds of granulocytes or monocytes that help in fighting infection. We have two types of immunity, so innate immunity and adaptive immunity. Remember, the innate immunity is hardwired, it's ready to go. It may need some activation, but the once the infection occurs, those molecules are ready to fight the infection right away within a matter of hours, compared to adaptive immunity that takes days before it can be activated. And however, once activated, it's very specific and sophisticated response that we get from adaptive immunity. So both of those responses are pretty important for our well-being. All right, so here is a picture of just a general immune response. So think of a kid walking barefoot on the ground and has a splinter in the foot. In that scenario, we definitely don't want the adaptive immune system to kick in over a period of days. We need something right there that can start fighting infections if that splinter has a virus or a bacteria on it that's now inside our body. So the first line of defense is always the physical barrier by skin and epithelial tissue. But then once that's broken, as in this scenario, there are these cells, macrophages, dendritic cells, mast cells, that are ready to fight those infections. They also send signals to the blood circulation so that they can ask for help. And the neutrophils are like the first responders who come to the site of infection to help in fighting that microbe off. Also, these dendritic cells are some messenger cells that take the message through lymphatic vessels to the lymph nodes where the T and B cells are resting. And once they get the message that there is an infection, these T cells start making a plan on how to fight that infection. And B cells also get activated. They go to the bone marrow, form plasma cells that give rise to IgM, and then that can later switch to GAE depending on the type of infection. So that's how our immune system works overall to fight any kind of infection. So that's just a short version of how our immune system would work. So then why are we worried when we are thinking of recurrent infections? Why are we worried about inborn errors of immunity? So as this figure shows, over the last several years, lots of inborn errors of immunity were discovered. But as you see, there is an exponential rise in last few years, to the point that we are at 485 different genes that can cause inborn errors of immunity. And that's from the update, sorry, that I did not update that. That's IUIS 2022. So and these are the 10 different categories of inborn errors of immunity that the IUS classification notes and updates every couple of years. So this is the paper that just came out, 2022 update, and it has 55 new genes that it mentions. That's since 2019. So this figure basically shows the new genes in red here, and they are in all different categories where we found most of those categories have new genes that we were able to look at. So how common are these? So as I mentioned, inborn errors of immunity are rare disorders. However, as a group, these are way more common. So one of the early estimates of inborn errors of immunity was when someone did a phone survey and called up general population and asked if they have an immune issue. And 1 in 1,200 replied that they had one. That was a very rough estimate. We know that some of the inborn errors are pretty rare, but there are also common ones like selective IgA deficiency, that is 1 in 300 to 400 people. With the newborn screen being implemented, we know severe combined immunodeficiency incidence is 1 in 58,000. Chronic granulomatous disease, thankfully pretty rare, 250,000, versus the newer defects. They are extremely rare, but also the exact incidence is not yet known because some of these patients are likely undiagnosed yet at this time for those. So then how do we evaluate these recurrent infections for inborn errors of immunity? So as the slide suggests, that a most important part of the whole evaluation is history. What kind of infections and where are these infections? How frequent are these? And were there any other conditions that could predispose to those infections? So all that plays a really big role in what we do, how we evaluate these patients. In practice, really everyone comes into our immunology clinic with recurrent infections. So how do you know which ones to focus on, which patients should get evaluation? So this is a warning sign chart that was established by Jeffrey Modell Foundation of Immunodeficiencies. And so this is mainly for just a rough guideline and more important for primary care, where they have an estimate which patients should be referred to immunology clinic. So overall, these warning signs, these warning signs, not particularly paying attention to how many infections of each type, but in general, if infections are more frequent than you would expect for that age and that kind of a patient, think of immunodeficiency. Again, failure to thrive, recurrent deep-seated infections, opportunistic infections, including just persistent thrush, need for IV antibiotics, family history of immunodeficiency. That's a pretty important fact, important part of the history that can help you determine if you need to do immune workup. Types of infections definitely plays a role in what kind of immunodeficiencies you should be thinking of. Sometimes that's revealing, sometimes it's not. So some examples where it might play a role is if you're seeing catalase positive organisms, so Serratia, Burkholderia, staph, molds, think of chronic granulomatous disease. Or if you see HSV encephalitis, we know that that can be caused by defects in TLR3 pathway. Viral encephalitis has been noted with X-linked A gamma globulinemia. There is a long list of immunodeficiencies that are associated with recurrent or chronic EBV infection. And then again, HPV, you can think of DOC8, you think of EVER1, EVER2, GATA2, WHIM syndrome. Wherever if you see patients have frequent warts or warts that are not resolved. So there's definitely a clinical aspect that you need to know. Kids can have warts if they are going away and not needing with usual treatment, then those might be just part of normal childhood. But something out of the ordinary, think of immunodeficiencies. Chronic mucocutaneous candidiasis can be part of an immune defect as well. There's one defect that's known to cause invasive fungal infections. That does not mean there might be several ones that we still have not discovered, but CARD9 is known to cause invasive fungal infections. And then our talk wouldn't be over without talking about SARS-CoV-2. So we know that SARS-CoV-2 infections led to all these studies that looked for immune defects that could predispose some patients to the infection and some patients to more severe outcomes and a severe course of infection. So we know 2 to 3% of severe life-threatening infections resulted from immune defects that are known to cause infections such as viral infections such as HSV or influenza. So there's a long list. One of the newer immunodeficiency that was discovered because of during the era of SARS-CoV-2 was a TLR7 defect. That was noted in about 1% of males with severe or fatal COVID-19 infection. All right, so that's definitely not a comprehensive list. It's just a list just to make you start thinking of immunodeficiencies in the perspective of what kind of infection you are dealing with or hearing about. All right, but of course, apart from infections, there are several other manifestations that you have to keep in mind. So inborn errors of immunity can be presenting with not just infections, but malignancy, lymphoproliferation, autoimmune features, granulomas, just atopy as a part of that picture. And so if you see a combination of these going on, sometimes some inborn errors of immunity don't really have to present with infections. So keep in mind there are other aspects of these disorders. So few of those examples: autoimmune features, CVID can present with GLILD or granulomatous lung disease. ALPS, autoimmune lymphoproliferative syndrome, can present with lymphoproliferation, again, hepatosplenomegaly, lymphadenopathy, that can be pretty prominent. 22q11.2 deletion syndrome, previously known as DeGeorge. Hopefully everyone is trying to use the new nomenclature here. These patients can present with autoimmune thrombocytopenia and other cytopenias as well. Lymphoproliferation can be seen with not only ALPS, but also XLP. Some of those patients can have EBV infection along with that. Malignancies can be part of that presentation in CVID, some of those antibody deficiencies like CVID or selective IgA deficiency or XLP, and several other combined immunodeficiencies that can present with malignancy. Atopic features are part of some of the immune defects such as STAT3, Job syndrome or DOCK8 defect, Viscott-Aldrich syndrome. So again, long list. These are just the examples. So, we talked about the history. Now we talk about the physical examination. And sometimes physical examination can be revealing for these patients, sometimes not so much. So if there are syndromes that are the inborn errors of immunity that lead to syndromes, then you might see some dysmorphic features. Some patients can present with failure to thrive, hepatosplenomegaly or lymphadenopathies. You might see some rashes that might make you think of specific immune defects such as Omen syndrome or Comel-Netherton syndrome, or there can be symptoms that can be part of a syndrome or immune defect, such as hyper IgE syndrome. Job syndrome can present with skeletal features and coarse facies. That's a part of it. Or cleft lip palate can be part of 22q11.2 deletion syndrome. Again, absence of a sign is sometimes a sign. So absence of tonsils, lymph nodes, that can be a sign of X-linked agammaglobulinemia or SCID. So keep that in mind. In a patient of appropriate age, that might be significant. Here's a picture of ectodermal dysplasia that can be prominent here in ectodermal dysplasia. Patients with specific inborn errors of immunity, such as Nemo defect. There are conical teeth. There can be skin issues. So the skin defects, hair are affected, nails are affected. So keeping that in mind. All right. So the big part of evaluation is lab evaluation. So always remember a couple of things to take home from this talk is any kind of immune evaluation should look at quantitative and qualitative data. And most of the lab results have age-appropriate ranges. So always look at age-appropriate normal range to compare to the results. And if I can tell you to take home any points out of the whole talk today, these are the two things that I would like you to remember. So let's think of each type of immune defect and what kind of test that we do. So if we are thinking of antibody deficiency, the screening tests would include immunoglobulin levels, IgG, A, M, E, all of those come in handy. Looking at the antibody titers to specific vaccines looks at the function of those immunoglobulins. And then if those are low, you can give them boosters and repeat the antibody response. Further testing for B cells would include flow cytometry, looking at total B cells, and then looking at naive and memory B cells. There are functional flow tests that are available, such as for agammaglobulinemia. You can look for a particular protein, BTK, and as such, there are similar advanced functional flow studies available. And then gene testing has become part and parcel of immune evaluation at this point. So we'll talk a little bit more about genetic testing in general after all these categories. Cellular defects. Here, the screening test would be just the basic test. CBC with differential gives you an absolute lymphocyte count. 70% of your lymphocytes are T cells. So if the T cells are low, that will reflect on your ALC, but your B and NK cells can be low and your ALC can still be normal. Flow cytometry, you can look for markers for T cells as well as B and NK cells. Testing for function of those T cells was previously done with this cutaneous delayed type hypersensitivity test, where we did a test similar to TB test, but with Candida antigen instead of tuberculin. And you waited for 48 hours to see if that site has a reaction. That reaction comes from CD4 cells. So in presence of reaction to Candida antigen, that's everyone should be exposed to that. If you don't see a reaction, that would tell us that the T cells are not functional. However, that's a subjective test. It's a in vivo test that needs a couple of visits. And so we have moved away from that test to the mitogen and antigen assay, where you use the T cells and expose them to plant products called mitogens or different antigens such as tetanus or candida or some antibodies, and look for proliferation of those cells. So that's your functional study. Newborn screening for SCID is now implemented in all 50 states of United States. So that has become a pretty important screening test for T cells. And then there are some advanced tests looking for the flow cytometry for markers of T cell defects, genetic testing. There is, I did write FISH, but we have moved away from FISH, so I should change that. So we typically do microarray testing to look for 22q11.2 deletion or any other types of deletion like 10p11 deletion that present similar to 22q deletion. All right, here's a picture of flow cytometer. Pretty much cells are from blood specimen are put in a file, so single file, and that moves in the flow cytometer where they are tagged with antibodies, specific antibodies looking for the markers, and then the laser light is shown here, and depending on the fluorescence, they might emit different types of fluorescence, and that's measured that can be used to recognize whether these are T cells, depending on markers like CD3, CD4, CD8, CD19 for B cells, or CD16, CD56 for NK cells. And that's just an example. There are several other markers that can be used with flow cytometer. You look at that light that's scattered. There's forward scatter and side scatter that you look at on the flow cytometry results to determine some of this information. All right, moving on to testing for phagocytic defects. So again, quantitative and qualitative. You can look at the CBC and look at the neutrophil count to determine if there is neutropenia or not. Or there are various tests that can be done for specific type of neutrophilic disorders like chronic granulomatous disease or leukocyte adhesion defect. And then genetic testing is important in some of those disorders. Here's the dihydrorhodamine test. Sorry, let me take a look. Okay, so for the chronic granulomatous disease, oxidative burst is the test that we perform. In the past, there was nitroblue tetrazolium test that is no longer used, at least in North America, and the test that we use is the dihydrorhodamine test. So what is that test? You basically use a blood sample, isolate neutrophils, and expose them to, they are tagged with dihydrorhodamine, and then they are stimulated, and if they have oxidative burst capacity, then they would be oxidized to rhodamine. That DHR is oxidized to rhodamine. Rhodamine is fluorescent, and that fluorescence is measured. So these are histograms looking at the fluorescence. If there is fluorescence in those neutrophils, the histogram shows shift in the curve here. So that shows normal patient, normal person without CGD. Here is a graph where there is no shift in that graph for fluorescence, and that means that this person has CGD. It's a CGD patient. Well, this one actually shows two peaks. One peak is for neutrophils that have normal oxidative burst, whereas some that do not have as much of oxidative capacity. And that would be a carrier for X-linked CGD, such as mother of CGD patient. So that's your dihydrorhodamine test. Complement defects. You can screen for the complement defects using screening tests called CH50, which is total complement, looks at classical pathway of complement, or alternative pathway, which is AH50. And there is a test for mannose binding lectin pathway. However, MBL deficiency is pretty controversial. Most of these patients are pretty healthy and do not have immune defects. Regardless, if you notice a defect in any of these screening tests, you can order individual complement levels. Innate immune function can be tested using specialized assays like toll-like receptor function assay. There is NK cell cytotoxicity assay, and better assay for NK cell function is CD107A marker. You can use flow cytometry to look for quantitative information on NK cells, and then genetic testing definitely is helpful. Apart from these, there are other lab tests that you should be looking at when you are thinking of immune defects. So think of secondary immunodeficiency, look for viruses that can suppress the immune system, inflammatory markers, peripheral smear. Some of these tests are really, underutilized. So think of these tests that can come in handy in your workup. And then biopsy of any affected tissue can be considered, and that might come in handy as well. All right, and then genetic testing. So why get genetic testing? So pretty obvious, this is 2022. There are 485 genes that we know now that can cause inborn errors of immunity. They can give you prognostic information. They can give you information about for the family, for planning of their family in future or patient's family in future. However, the most important part is that some of these genes can give information that can be used to target specific molecules and can be used therapeutically. All right, so again, going back to medical school, the genetic material is in the nucleus, and it's in a compact form in the chromosome, and that has the DNA. Genetic information flows from DNA to the RNA and then protein. Right now, all genetic testing that we use clinically is mostly we are focusing on DNA studies, right? So there are a library of genetic tests that we utilize. And when I say library, the reason I say library is it's pretty much different types of tests that are available that we use depending on what we are looking for. So let's look at that library of these genetic tests here. When do you use different kinds of genetic testing? And so I want to give you an example of you standing in the library and you are in charge of finding errors in the library. And that could mean you are looking for a missing book. And if you're looking for a missing book, you can't be standing next to the shelf and looking at one book, because then you are going to miss what's actually missing. In ideal world, if everything that's missing has an empty space, you can actually move back and see if there is anything that's missing, any book that's missing. Now, if we take that far away look for our genes, that's something like looking at a karyotype. You're just having a far away look and looking at if there is a chromosome or a piece of chromosome that's missing. And so if you are suspecting that kind of a disorder that could be caused by a missing piece of chromosome, then think of using karyotype. there can be smaller pieces of chromosome that could be missing. And that's like missing page in a book. So if you're in a library and you have to actually look at, are there missing pages in books? You can't be further away from the shelves and looking at that. You have to go closer, open the book, and actually flip through to see what page is missing. And that's your microarray. You're actually looking for a missing piece of chromosome or missing page in a book. That's your microarray. So that's something that we use with 22q11.2 deletion. That's just an example. There are several other defects that can be looked at. Those are called copy number variants or SNPs, which means there is a change in the genetic information or nucleotides. So then there are times when there might be a word or an alphabet missing in a book. And when you want to do that, you can't be flipping through a book. You actually have to go line by line and look for missing words or alphabets, and that's your genetic alphabet soup. These nucleotides can be switched. So one might be replacing other, or they might be missing. And to get that information, you really need to be having a very close-up look at that each page. And that's your sequencing results. So now imagine you are in charge of looking for one kind of information, whether it's a missing book, missing page, missing word, or alphabet. If you are choosing a different test, so if you're very close by and flipping through a book, you are going to miss that information about a missing book because you're looking at missing pages. And so same thing, if you order a sequencing result, and if you think that you got all the information you needed and you didn't find the answer, think about what's missing. You might be missing that far away look where you need to look at a microarray and look for that missing word or a page. So that's your sequencing results where you have a very close by look, but those are different types of sequencing tests that are available, like single gene sequencing, gene panel sequencing, or exome sequencing. And so single gene is where you know exactly what's going on with this patient. This patient doesn't have, has very specific features for example, X-linked A-gamma globulinemia. You're looking for a very specific gene, just order that gene sequencing for that gene. If you know the phenotype, such as SCID, but you don't know what gene could be causing that, you could order a gene panel for sequencing, which would give you a specific number of genes that are sequenced to look for the cause of the problem that's going on. And then really, if you have a disorder that's going on that's more complex, such as very early onset IBD, these patients can have variety of different genes that could be affected. You really don't want to order a panel and then find out, well, you didn't get an answer and order another panel and then another panel, and that's not cost effective. So we suggest using exome sequencing in that case. And then if you have an undiagnosed inborn error of immunity, you didn't find an answer through all these tests, and you still have very high suspicion of having an IEI, think of genome sequencing. There is RNA sequencing that's available. However, it's all research-based. It's I believe at least most centers are not using RNA sequencing yet for clinical use. All right, moving on from all the workup that we talked about, now we want to know what kind of inborn error of immunity are we thinking of. So as you can imagine, there are 485 genes. We are trying to figure out, it's like a needle in a haystack situation where we are trying to figure out what immune deficiency should we be thinking of. So going back to our list of inborn errors, these are the different categories. And when should we be thinking of which category? So that's what we are going to focus on for the next few minutes here. So let's think of B cells and immunoglobulin defects. Again, in here, the defect lies in B cells, so that innate immune system will still work when there is a splinter in the toe, and it will still do its job. But when that message reaches the B cells, they may not make the antibodies as they are supposed to. And the big questions that you have to keep in mind are, and try to answer, are there B cells? Are there enough immunoglobulin levels, and if those immunoglobulins are functional? And based on that, you can actually figure out which kind of B cell deficiency you are thinking of. And here's a list. So the common features of B cell deficiencies are sinopulmonary infections. They can have GI infections. And so let's look at some of these. So AGAM patients, these patients do not have immunoglobulin levels. So IgG, AM can be pretty low, and because they don't have those, they don't make response to vaccines, which is how we check for functional antibodies. And when you check for flow cytometry, you will not see B cells, or there are no functional mature B cells in the circulation. There are several genes that can cause AGAM. Most of them are pretty rare. They are autosomal recessive. The most common and among these is X-linked AGAM, which is BTK, and that's your typical AGAM that you hear about. These are boys who present around 3 to 6 months of age with bacterial infections. They can have viral infections. Enteroviral encephalitis is something that has been noted with these patients, and then treatment is replacement with immunoglobulin infusions. Common variable immunodeficiency, here B cells are normal in number, but somehow they don't function enough, so the immunoglobulin levels are low. IgG has to be low. Along with IgG, either of IgA or M have to be low, and they do not have good response to vaccines. And those are the criteria that have to be met, along with they have to be at least 2 years of age, and other immunodeficiencies that could explain those features have to be ruled out. These patients, apart from presenting with infections, as the name suggests, can have variable presentation with autoimmune features, malignancies, granulomatous disease, and then treatment is with immunoglobulin replacement. But again, non-infectious issues can lead to need for immunosuppression or biological use. Selective IgA deficiency, here B cells are normal, IgG and M are normal, but IgA will be low, and they do not have a good response to vaccines. They sometimes can have, variable response to vaccines. So sometimes their response will be completely normal, sometimes it can be low. So these patients can be asymptomatic, or sometimes they'll have infections. They can also develop autoimmune features, or over time evolve into common variable immunodeficiency. Diagnosis is after 4 years of age. So if you see a low IgA before that age, you might want to wait before you label them as IgA deficiency. Treatment depends on what's going on. They can be monitored, or if they are having infections, they may need preventive antibiotics or immunoglobulins. Specific antibody deficiency, here the B cells are normal, immunoglobulin levels are normal, but they don't make vaccine response. And that can be part of another immunodeficiency, or that can be present by itself. And then again, the treatment is pretty similar, giving them vaccine boosters, prophylactic antibiotics, or immunoglobulin replacement if other options fail. Another condition is transient hypogam of infancy. Here, the B cells are normal and they have good response to vaccines, but for initial time in their infancy or a little later, their immunoglobulin levels can run low. So their maternal immunoglobulin from the circulation disappears around 6 to 9 months age, and the baby's immune system should take up the job of making antibodies. If that job is delayed and the immune system doesn't do a good job initially, they can have low immunoglobulin levels, but the immunoglobulins that they make are normal functionally, so they can make good response to vaccines. And that can continue till 2 to 5 years age and should resolve by that time. Most of these patients are asymptomatic, but they can have infections and then sometimes can need similar treatments as for other antibody deficiency. Moving on to T cells, again, the innate immune response may initially be normal, but the message reaches the lymph nodes and then T cells don't do a good job, and that's your T cell deficiencies. And the questions you want to answer, are there enough T cells? Are T cells helping B cells make antibodies? And are T cells able to perform cytotoxic or killer function? And then are they able to regulate the immune system? So here are some of the immune defects or categories that you want to think about. So these patients will present pretty early in life when we talk about severe combined immunodeficiency. Infections can be all different types. So bacterial, fungal, viral, opportunistic infections. These can be pretty life-threatening. They can have recurrent rashes or recurrent diarrhea, failure to thrive, and SCID is fatal unless treated promptly. Thankfully, the newborn screening for SCID can now pick up these patients pretty early and they can be treated. Treatment involves stem cell transplant, gene therapy is available on research basis, and then enzyme replacement is available based on some types of SCID. So for SCID, you want to know the phenotype of SCID, which type of cells are affected. Apart from T cells, you want to look at B and NK cells if they are present or absent. And so based on those, these are the subtypes of SCID. And here is a long list of different genes that can give rise to different types of SCID. The most common type is common gamma chain or IL-2R gamma defect, which is X-linked. And that causes T minus NK minus B positive SCID. So again, not going into details of each subtype for this talk, but again, it's really important to know the phenotype of SCID. Newborn screening looks for a marker of T cells. So the dried blood spots are punched, and that punched hole is used for running a PCR for something called TREX, or T cell receptor excision circle. If that marker is not seen and the screen is abnormal, then you need to run flow cytometry to look for presence of SCID. There are several false positives or other conditions that can lead to abnormal newborn screen for SCID. So here is a picture that shows how the DNA in T cell rearranges, and how we use cut and paste kind of option when we type on the computer. Our DNA in the T cells actually uses cut and paste kind of option. So what it does is it cuts out a part of the DNA and the rest of it joins each other. And that cutout portion makes a circle called T cell receptor excision circle. And that's a marker for T cells. So 70% of your normal T cells should be making these. So if these numbers the TREX are low, then you want to look if the T cells are truly low or not. There's a lot of information that we can go over for SCID, but here is just one slide to go over what SCID is. Less than 300 alpha beta autologous T cells with lack of function of T cells is typical SCID. There are other reasons for abnormal screen for SCID that I'll let you guys look at later. There's a long list of combined immunodeficiencies that can be present that's not in SCID. Don't want to go over each of these genes, but you want to know some of these features: MHC class 1, class 2 deficiency, or Bair lymphocyte syndrome, or some of these patients can present with variety of different infections. Just kind of keeping in mind that even if it's not SCID, some of these patients who present with either low T cells or abnormal function of T cells can have different reasons for presentation. Hyper IgM syndrome, where the B cells can make IgM, but for them to switch to G, A, or E, they need help from T cells. And if the communication between T and B cells is lost, then then these patients have hyper IgM. There are times when the B cell itself has a defect that has problem with class switch from M to other ones, and that also gives rise to hyper IgM syndrome. And so these patients can have severe infections if the defect is in CD40 ligand or CD40, where that's a combined immunodeficiency T cell defect. These patients can have opportunistic infections. If the defect is in B cells, just a antibody deficiency, then some of these patients may not have opportunistic infections. Treatment depends on the presentation. Most of these patients, the severe forms, need stem cell transplant. Some patients may also need supportive therapy, and depends on the type of the defect. All right, so there are some syndromes that are present that can present with combined immunodeficiency, and you'll come across these a lot, and likely you know most of these. So Wiskott-Aldrich syndrome that can present with thrombocytopenia and eczema, ataxia telangiectasia presents with, as the name suggests, along with immune defects. 22q deletion syndrome can present with congenital anomalies, all midline defects, along with infections. Cartilage hair hypoplasia, they have bone defects, short stature, Job syndrome or hyper IgE syndrome. They can have skeletal features as well. And again, the list goes on. I'm going to move on to the next category here. All right, so some of these are described in more detail. Defect for Wiskott-Aldrich is in WASP-P gene with the triad of symptoms, and treatment is stem cell transplant. Gene therapy is available as on research basis. 22q deletion, as the name, as I mentioned, there is defect in midline organs, so third and fourth pharyngeal pouch development issues, so heart defect, hypocalcemia from hypoparathyroidism, and thymic issue. Most of these patients have milder immunodeficiency and need supportive therapy. Less than 1% have complete aplasia of thymus and do not make any T cells, and they present like SCID. And those patients would need thymic transplant ideally, and bone marrow transplant might be an option. Hyper IgE syndrome, here is a characteristic facies of with coarse features for Job syndrome, but there are other features that are present for some of the other immune defects. Phagocytic disorders, here again, we think of neutropenia. Some of the neutropenias can be severe, and there are some called severe congenital neutropenia, and there's cyclic neutropenia, so lots of different neutropenias that can be genetic in origin. Other defects are functional, like leukocyte adhesion defect or chronic granulomatous disease, and these patients overall as a group can present with wound infections, wound healing issues. So skin infections, abscesses, or lack of pus, osteomyelitis, granulomas, gingivitis, pneumonia are typical infections that you'll hear about. Leukocyte adhesion defect is like a doctor who is on call going home, and if you are called in, you have to actually, if you're going on a freeway, you have to move to a slower lane and come out of the freeway and go back to the hospital where you are called from. Same way, neutrophils are first responders. If there is an infection, they are called upon, but when they try to get out of the circulation, they have to move to the slower lane, apply brakes, and once they do that, they can come out of the circulation and go to the site of infection. If that doesn't happen because there is leukocyte adhesion defect, their brakes fail, so they continue to flow in the circulation. They are trapped in circulation, but then they cannot go to the site of infection, so they can't form pus, and that causes these patients to have infections. However, there's lack of pus. That's your leukocyte adhesion defect type 1. That's the most severe, present pretty early in life, and treatment is stem cell transplant. LAD type 2 and 3 are less severe and present later in life, and they might need supportive therapy. Chronic granulomatous disease. Here, the oxidative burst capacity of neutrophils can be affected. So the neutrophils can go to the site of infection, perform phagocytosis, so engulf the bacteria or the microbe. And once it's inside, they have to use their machinery called the enzyme system called NADPH oxidase system. If that's defective, then they cannot kill the microbe. And so that machinery can be defective in various genetic defects that cause chronic granulomatous disease. This disorder puts them at risk for catalase positive organism infections. And as we saw, the diagnosis is by the oxidative burst test, dihydrorhodamine test, and then treatment is stem cell transplant, which is curative. You can put them on triple prophylaxis with antibacterial, antifungal, and interferon gamma, and that can be a supportive therapy. Complement defects, I'm going to go over time here, but we did start a little later, so I'll take a few minutes. I understand if you do need to leave, but let me take a few more minutes. We are almost done. So complement pathway, we looked at different pathways that can be analyzed, classical, alternative, or MBL pathway. The early part of the complement, if it's defective, can cause infections similar to antibody deficiencies, but this late complement or common pathway defects can present in a little different ways. So early complement defects, sinopulmonary infections, and autoimmunity. Late complement defects present with encapsulated organism infections, such as Neisseria meningitis or disseminated infection. Defects in innate immune system, there are lots of different types. There are several different categories, subcategories in this category as per IUIS classification. The big ones are Mendelian susceptibility to mycobacterial disease, having epidermodysplasia verruciformis, as well as other different viral infections. So again, I don't want you to focus on the gene names, but that's something that you'll over time realize that you'll get accustomed to looking at. Mucocutaneous candidiasis or invasive fungal infections are other categories that have several genes that can predispose them to those defects. We look at the dendritic cell defects or defects that are caused by recognition receptors, such as toll-like receptors. These are pretty rare. They can have severe infections like mycobacterial infections, other viral infections like HPV, HSV. They can present with ectodermal dysplasia and those kinds of severe phenotypes. So some of those are depicted in this particular deficiency called TLR pathway deficiency. There are again different types. There are some that are called IRAK4 and MyD88 that can present with pyogenic infections. TLR3 pathway defects lead to HSV encephalitis. And then there is another one called TYRAP deficiency that causes problems with staph infections. And then NEMO defect gives rise to the what we talked about, ectodermal dysplasia, mycobacterial infections, severe bacterial and viral infections. NK cell defects, these are again pretty rare, and they might actually now be classified in different categories, such as GATA2 is defined, is one of the defect noted as a phagocytic defect. So apart from NK cells being affected, they can affect other cells as well. CD16, MCM4, those are combined immunodeficiencies where NK cell deficiency is pretty prominent. Some of these patients can have severe viral infections, so disseminated EBV, disseminated HSV, so kind of keeping that in mind. And then there are some disorders of immune dysregulation, which can present with specific types of infections. So most of these present with non-infectious issues, but some of them, such as susceptibility to EBV, can present with not only EBV infection that is hard to treat, but also malignancies or lymphoproliferation. So infection by itself, you can treat it, but you have to know if there is a underlying disorder that is predisposing them to have other problems. So again, some of these subcategories like regulatory T cell defects, FOXP3 or IPEX deficiency, that can lead to recurrent infections as well. So these are some of the defects that have other autoimmune features along with infections such as viral infections or fungal infections ongoing with them. All right, that was my last slide. I'll stop here and take any questions.
All right, any questions from the audience? All right, sorry we had a late start for you.
Oh, that's all right.
The people hanging in there through this. I did put in the chat here, immunodeficiencysearch.com is a great resource you might want to look up and have available, make them their favorites because you'll use it frequently. I look forward, Dr. Raje, for you creating the perfect algorithm so we just can put in data and it tells us what to do next. The immunodeficiency does have an algorithm, but it's multiple algorithms, a little bit fragmented and all that. But as the genetic component continues to endlessly grow, it's hard to keep up on this, and it's going to take machines to help us more than our own knowledge, unfortunately. So
True, yeah.
Okay. All right. Quick question for you. IgA deficiency, very common. They're greater than 4. They have persistence of the deficiency. Do you follow them yourself clinically in your practice to kind of monitor over time? Do they become a CVID, or do you pretty much give the family counseling and say, hey, if we start getting recurrent unusual infections, frequency, severe infections, kind of the hallmarks of what we need to pay attention to, just, get referred back in.
Right. So if they come before 4 years age, which means they are not defined as IgA deficiency, then I tell them to follow up with PCP, repeat the level after 4 years age, and if it's still persistently low, see us again. Once they are diagnosed with IgA deficiency, most of those patients, we talk to them about whether if they develop more infections or autoimmune features, they might have more significant deficiency compared to others, and they do need to see us. We do offer them that if they are more comfortable seeing us once in a year or two, they can. Most of them fall off after a few years. The ones that we actually hang on to are the more severe ones. So we do have IgA deficiency. Most of these patients just need prophylactic antibiotics, and they do pretty well. So we have some who continue to have infections, get hospitalized, and at some point you have to say IgA deficiency is the one that's causing that. And some of our patients are doing pretty well, but they do continue to follow us because they are on therapy. So those are the ones that we follow for sure. The other ones have an option. Most of them don't come back as frequently.
Yeah, I find that several of them come back for a few years and then they just get, right. I'm okay, I'll see you if I need you. And then I do have some from, years ago who kind of continue to come in yearly just to get checked. Their history is not suggestive. I don't think they need it, but I do it out of maybe a little bit of my own ignorance or giving in, and then, the fear of the family. So that's shared decision making as usual.
Yeah, and I think one thing to keep in mind is that low IgA, when you initially see it, it might be and even though they might not meet the criteria, it might be part of a bigger picture. So as long as you have looked at the rest of the immune system in the right scenario when they're having infections, to make sure that you are looking at not just the IgA, even if that's the only thing that you are seeing is low, but looking for any other causes.
Yeah, exactly. Okay. Well, if we have no more questions, we'll go ahead and end this. Thanks for a great presentation.
Great. Thank you.
Okay. We'll see you all next Monday for the next go round of this. Thanks.